Hey guys, today we're here, the Athlete Engineers, with Dr. Mohammad Rimawi. We're going to go with Mohammed today. We're so excited to have him here. So can you tell us a little bit about, your background, your education, what you do?
Yeah, sure. Thank you for having me, guys. I've seen a lot of your work, and I had to reach out and make this happen for sure. So my name is Mohammad Rimawi. I'm a foot and ankle surgeon working out of New York City. I got my medical degree at the New York College of Podiatric Medicine. I then did my training at two different institutions. I started my first year at a place known as the Podiatry Institute in Decatur, Georgia. I then completed my training over at Jefferson Health in Philadelphia, which was a very high-end trauma energy program. I mean, we were seeing everything from ankle fractures, Achilles ruptures, to open fractures, compartment syndrome. It was a great experience there. So I'm excited to talk about this topic. It's something that I've seen firsthand, and hope I can give some benefit to the listeners here.
Awesome. Yeah, we're really glad to have your perspective. We're on the physical therapy side. Jake's seen it from the athletic training side, and even on the strength and conditioning side. So to give everyone a little taste of what we're doing, we're talking about Achilles ruptures. We might brief that into some Achilles tendinopathy. We're going to talk about how they happen, just the mechanism injury behind it, some risk factors for it. Then we're going to get deep into the surgery and the rehab and some prehab, so you guys can get a better idea of what we're working with. And if you experience this, it's crazy. The statistics, it's risen dramatically over the last decade and all the way back to the last 30 years. So I don't know if you could speak to that at all, in what you've seen with these injuries coming in. Any ideas of why that might be rising?
Well, we're getting healthier, right? So we're able to do things at different ages now, whereas before you had this window of opportunity to be athletic and fit. Let's just say for this conversation's sake, from 20 to 40, that's when you're gonna really go after things and increase your activity and train and whatnot. Now it's not uncommon for that to be 30 to 50. I mean, runners, there's no age limit, athletes, CrossFit, HIIT training, whatever it may be. So that increase in the healthy state of America, I know we talk about different things, but in terms of fitness, that increase has caused a increase in Achilles ruptures. And it's not just Achilles ruptures, but all types of different pathologies. So that's what's caused by it. So it's a good and a bad. When we continue to advance in the health field and the training and whatnot, we're going to see more and more pathologies and things we've never seen before, just because more people are doing it at a more advanced age. Now, as far as the Achilles tendon, I think it's important that we touch on the anatomy of the Achilles before we move forward, right? So the Achilles tendon is so important. It's the longest and strongest tendon in your body, correct? It measures
Yes,
about
sir.
15 centimeters long. It can withstand, some reports say, 10 times your body weight during certain activities, right? So it's a very demanding tendon. Now it's separated into three different structures. So in the most proximal aspect at the myotendinous junction, which is basically where the muscle meets the tendon, it's very vascular, and that's important. We like that. Now the very bottom section, which is called the insertional section, it's where the tendon meets the bone. It also gets some blood supply there. Now there's this area called the watershed area, which is about 2 to 6 centimeters above the insertion. This is the area where a lot of our problems begin to happen. And when we continue this discussion, you'll notice a theme about blood supply, blood supply, blood supply. Because we all know when we go through injuries or even hurt ourselves in any demeanor, the only thing that really factors in the beginning or the acute phase is, do you have enough blood supply for your body to get those growth factors and those healing factors into the area? Now, if you're already prone to a lack of blood supply, you could imagine how difficult it may be to heal a certain area. So that's important as far as the Achilles is concerned. Now, the demand that we expect from the Achilles is obviously robust, right? We're talking about just driving a car. When you're pushing the gas pedal, guess who's mostly acting on that? That's the Achilles. So we're talking about, people love to talk about athletes, but I see a lot of non-athletes with Achilles tendinopathy, from truck drivers, from women who wear prolonged heels, who are constantly in what we call a plantar flex position, so their ankles constantly down. That puts some strain and tension on the Achilles, depending on the size of the heel. And then, of course, we have our athletic population. The athletic population, I mean, the competition has increased drastically over the year. So people are just pushing themselves more and more than they're accustomed to, and that's caused a rise in injuries. Now, the idea between what you mentioned is we're going to talk about injuries and how we can prevent them, right? Prehab is now huge. Whereas before, when we talked about Achilles tendinopathy, it was just, okay, you have it. Either we're going to do surgery, conservative management, and then get you into rehab, and we'll see you back in sport 6 to 12 months. Now it's like, okay, Achilles tendinopathy, Achilles ruptures, it's becoming quite prevalent. So maybe we should develop a regimen to make sure that we don't see this as often. So as far as Achilles tendinopathy, we have to look at the factors for what may cause these conditions and these ruptures. And they're separated, and I'm sure the schooling is the same everywhere, into intrinsic and extrinsic factors. Intrinsic are things that are within you. You can't really change them. It's the way you were born or something you've inherited over time. This could be from your foot type, from certain conditions such as diabetes or obesity or hyperlipidemia, and so forth. Extrinsic are things we can control, right? This is proper training, proper footwear, the terrain you work on. These are things that within our abilities. And that kind of gives us an idea of what causes these things and what we could prevent them with. Now, in terms of diagnosis of the Achilles tendinopathy, this is a clinical diagnosis, okay? A lot of times the patients will come, whether they be in the acute or chronic phase, they'll complain of mild or vague pain in the back of the heel or the back of the Achilles tendon. They'll state it's stiff, it's painful. They'll notice for prolonged periods of immobilization, that moment when they try to act or try to activate the Achilles, it's a time of pain and aggravation. So just from the clinical examination or the history, believe it or not, alone, you could kind of diagnose these things. And a lot of physical therapists I work with, they'll send me patients and they'll say, oh, this patient has Achilles tendinopathy. They'll just know, they come in there. Right. Now, as far as rupture, we tend to hear the same type of story as well. Oh, I was just standing and it felt like someone hit me in the back of the ankle. I'm not sure what it was. Sometimes it's so impactful. Someone will say, I thought someone shot me and I heard a gunshot, because the pop from the Achilles can be that big or crucial. These patients, you already jump on Achilles rupture, and on clinical exam, you'll notice certain things. They'll lose the plantar flexion strength in comparison to the opposite extremity, and what we call a palpable dell. So that's something I document in my note, or try to document as frequent as I can. And what I'll do is I'll run my hands behind the asymptomatic Achilles, and it'll be a nice long tendon. And then I'll run my hand through the symptomatic Achilles, and you'll actually feel like a divot or a big dell. And that'll tell me, hey, there's a high chance you have a rupture. Now, where the game has changed drastically, like you said in your beginning, is how do we go forward once we diagnose the Achilles tendinopathy and the Achilles rupture? That's when it's changed in abundance, all right? As far as tendinopathy is concerned, it's usually separated acute phase and chronic phase.
Actually, before we go forward, can I hop in real quick?
Of course, yeah.
Awesome. So let's break down the different stages of what a rupture could be at, because a very common misconception is, hey, Kobe Bryant, that thing ruptured and it rolled up his leg and it was gone. Mm-hmm. So I think it's important for our listeners to understand that, hey, it doesn't all have to be gone, but you could be dealing with half, you could be dealing with a couple centimeters. So Can you speak to that a little?
That's actually a great question. So one common theme we're going to see with treatment protocol, it's going to be based on the individual. Like there is, we've shared the same articles. There is no uniform standard for how to treat Achilles rupture. It's usually individual based and what we called a shared risk. So basically we go over the pros and cons of each treatment, and you and the patient kind of make that decision together. As far as Achilles ruptures, there's different variants of that. So there could be called what's an insertional rupture, meaning where the tendon meets the bone, that's where it just snapped and popped, okay? And that's a really high energy rupture. I mean, for the tendon to come off the insertion where it's the strongest point of attachment, you did some serious damage on you. Now, as far as ruptures are concerned, we use what's called a Kawada classification. And this was like for a surgeon's technique based on the size of the rupture indicates what kind of surgical procedure you'll do. So if it's a partial tear, which isn't a complete rupture, this could either be diagnosed with clinical exam, ultrasound, MRI. We tend to be conservative. There's no need to go in there and do anything. Surgery is an invasive procedure, and if we could avoid that, then we should. Then there's the under 3 centimeters category. If it's under 3 centimeters, that gap tends to be small enough where you can reapproximate the tendon ends. So if you could kind of picture 3 centimeters, it's about this size, I could kind of pull those together and make sure they heal in an optimal fashion. Now, where it gets tricky is when it's above 3 centimeters. So when it's about 3 to 6 centimeters, now you have to look for a substitute. So we're going to need to bring in some graft material or something extra to kind of help this tendon in the healing phase. And anything above 6 centimeters, now we have to do what's called a gastroc lengthening procedure. And there's different procedures we could do. But basically what happens, just like you said, the tendon is ruptured and you have the proximal end going into space, right? There's no way I'm going to bring that proximal end and attach it to the distal part, right? So what I have to do is I have to go really proximal and cut that tendon. Really, it's just a controlled rupture just to kind of bring it down some to a point where I can reapproximate that tendon. And again, it's once you do Achilles surgery or dissection of Achilles, you kind of have a greater appreciation for the pathology. And again, that's all patient dependent on what we're going to do. So if a patient has under a 3 centimeter gap, let's say it's, for the sake of this conversation, a centimeter, right? Centimeter is not that bad. I mean, if you put them in a plantar flex position in a cast, those ends can touch enough for them to heal. And if the patient isn't looking for any demand, he's not an athlete, he's not a football player or anything, I don't see that it's negligent to use that as a treatment protocol. So again, it's hard to give a basis or a general description of surgery when it comes to Achilles rupture. It's an individual base, and it's going to be like a patient doctor relationship in terms of what you're going to do moving forward. So that's kind of why it's important to get checked out, really.
Definitely. Yeah, no, this is really cool because I just covered a water polo event this evening. We had a baseball athlete at the same school who tore his Achilles that day. So he came in and I was talking to the athletic trainer. I was like, we just went over this study in class where it says that our re-rupture rate between a surgical versus a non-surgical approach is the same. And the complication rate for surgical is a little bit higher, but the biggest thing is that your function doesn't change. And a lot of studies say that your return to sport is actually a month sooner in non-surgical than surgical. So it's really interesting because, like, even as a young athletic trainer, I always thought that, if it ruptures, it's surgery no matter what. Like, I never thought not having surgery was an option until you kind of look at it from an objective approach and you're like, wow, like this thing can really happen, which is crazy. Because, like, you're right, though, like with the small centimeter gapping, there's no way that, like, it's for sure going to approximate if you put that in that position long enough. So it definitely makes sense. I just never thought about it in that direction until recently. And I love that we found that.
I agree with you completely. That there's a big study that we both knew about before we discussed, and it kind of changed the game because, like you said, rupture was always surgery. And then they came out with this huge random controlled trial, which I hope we attach with this video. Everyone should, if you haven't read this.
Absolutely.
You have to read this. Even I
over 15,000 people, man. It was massive.
It's like a really an epitome of studies. My only criticism of that study is the gap wasn't mentioned, right? So when we talk about non-operative versus operative, you have to really assess the gap because there's no way you're doing a 5 centimeter gap and saying, I'm going to treat this non-operatively because your function is going to be the same.
Absolutely.
But what that study did shed light on is the complication rate. I think the complication rate of surgical was 16% compared to non-surgical, which was like 1% or some crazy number. There was like a vast difference between them. And I've seen it. One of the things they didn't mention in that study is wound dehiscence. That's very common. I mean, with Achilles surgery, depending on how much exposure you need, I know now they have minimally invasive things, but if it's serious enough, you're going to have to see the whole thing. That wound area, the blood supply isn't the greatest. So sometimes it just opens up and now you're dealing with wound care. So now that's something extra on top of the tendon you got to worry about healing. You have what's called the sural nerve there. Sometimes that area scars down too much and that sural nerve gets entrapped. So now these people got painful, tingling, numbness constant. And it's something you talk about with the patient. DVTs was a big thing back in the day. Now that prophylaxis is common. Any patient immobilized in my practice gets Xarelto. Like it's no question. 325 aspirin BID or Xarelto. Why even take the chance at this time?
Yeah, absolutely.
Yeah, no, and it's interesting because the top 3 ones, going from least to highest with those complications is infection. And obviously you would think of that more with the surgery and open things up. And then DVT. And then the top one was re-rupture. So I guess how many times have you seen that patient coming back in? You're like, hey, let's do it again.
I've seen it. There's no shame to say I've seen it. In the program we trained at, I was fortunate enough to work with a great trauma surgeon. He was phenomenal. And the pattern we noticed with people who re-ruptured it was unfortunately the obese population. It was very common for them to re-rupture, and sometimes we would actually adjunct the surgical fixation, the reapproximation of the tendon, with what's called an external fixator. And this is like a big rod with 2 pins in it. And the idea was this external fixator is going to give us the bony stability we need to keep the ankle in a plantar flex position. So there's little to no chance this person can do a slight movement or an abrupt motion that'll rupture this site. Unfortunately, but there's more risk factors for re-rupture. Diabetes is a big one. Lack of blood supply is another one. I've also seen people who can't take the fiber wire, so their body rejects it and spits it out, and that causes some problems. So it happens. There's no surgery without risk. Podiatry and foot and ankle surgery, they tend to be on the lower end of the risk spectrum, but they still a risk always.
Definitely. When I first came in the field, one of the big things that we kind of correlated, it was 80% within 18 months. And that was 80% of people that have a tear within 18 months are more likely to tear the opposite side. And it's really interesting looking at that because, I mean, that's obviously a drastic number. But when you start breaking it down, it becomes more that it wasn't so much the Achilles itself, but people never fixed the biomechanical errors that the people were experiencing. So we started talking about the risk factors, like the dorsiflexion or the lack of it. We actually had he's an adjunct professor at our school, Dr. Brian Bariani. He did a research paper that broke down different risk factors for injury, specific to Achilles ruptures. And he found that anybody that has less than 11.5 degrees of dorsiflexion has 3.5 times more risk for Achilles tear or just a general tendinopathy. And then subtalar range of motion too. Anything over 32 degrees of inversion was 2.8 times more likely, compared to under 25% of total passive range of motion is just at risk for Achilles tendinopathy. But these numbers, it's something that we can prehab through, we can stretch through, we can mobilize through. But it's just recently that started becoming to the forefront. But, that's part of the wave of this whole new medicine thing that we're bringing out is that we can treat an injury before it happens and prevent it from ever happening in the first place.
Yeah, I love it. I think eventually it's going to take me out of business, this whole prehab for that. It really is. It really is. But I'm happy that it's a thing because I always preach, you got to find the root of the problem. Otherwise, if we're just treating symptoms, we're putting Band-Aids on a wound. That's all it is. Sure, the wound will heal, but if you don't get what's really causing this, it's going to come back. And in those biomechanical aspects, that's the root of the problem. If you don't fix the fact they have lack of ankle dorsiflexion or they're in fixed equinus and they're putting constant strain on the Achilles, chances are it's going to happen again. So what they do, and I'm sure you guys could preach to this, athletic trainers, is a lot of times they'll give these athletes a full workup from top to bottom. And they'll tell them, listen, you're more prone to A, B, and C, so we have to work on strengthening 1, 2, and 3. And it's great.
Yeah, so I'm about to give a shameless athletic trainer, physical therapist plug here, but everyone needs to be analyzed. So everyone's got something wrong and everyone is at a higher risk for some sort of injury. But when you go to a specialist and you can see this, and even someone walks into your clinic, they could ask you and you could probably tell them what's going on. You'd be like, hey, this isn't moving properly. We could work on these certain exercises. We could work on these mobilizations, stuff like that. And we could help prevent these things, especially when it comes to athletes, younger athletes too.
Yeah, I was on a podcast recently and I said this earlier because for me, so far, the patient population that takes their craft seriously in my neighborhood are runners. I see runners, they come all the time. They're just for a pure evaluation. If they need orthotics, what kind of sneakers are best for them, what's their foot type, because they know if I were to get injured, this is going to really hinder my training. I can't afford to get a stress fracture. I can't afford to be delayed with tendinitis or tendinosis. So let me make sure that doesn't happen because I know if I get a fracture, that's 4 to 6 weeks. I can't even fight that. If I get tendinitis, there's no rhyme or reason to when tendinitis is gonna stop, or chronic tendinosis. I tell patients all the time, this could resolve in weeks. Don't be surprised if it's months. It could. That's not absurd to me for someone to come in and say, I've been dealing with this for 3 months. It's absolutely common. And it takes consistency. So if I could preach one thing to these athletes or people who really want to perfect their craft, this is an investment. And part of that investment is a proper evaluation. If you really believe in what you want to do, you want to get a scholarship from it, maybe play overseas or play professionally, you have to take it serious.
Absolutely. And going from the athletic training kind of portion of this too, a little bit mixed with PT, there's kind of three big areas we look at for runners. The first is like arch awareness, like knowing where your arch is at, if you need support, if you don't need support. The second part that kind of goes with that is what type of shoe you wear while you run. So for supportive shoes, you kind of want more of like a 300 to 500 mile range, as opposed to like a non-supportive shoe is more of a 200 to 400 mile range. So that's where you cycle your shoes at. The last big one though is your foot strike pattern, and people don't appreciate enough how much foot striking affects everything above the chain. So we know it's a lot like with these heel strikers, that decreased dorsiflexion that they're getting with every stride, that's really putting so much pressure on the hind foot. It's putting pressure on that Achilles tendon, as opposed to if we were to shorten their stride length, get more strides within so many seconds, things like that, that they're going to get that more controlled dorsiflexion. They're going to get that more controlled plantar flexion if they're more of a midfoot to forefoot striker. We'll see a lot difference in the injury rates that we see. So, I mean, it's crazy the amount of runners that are out there that are just running without knowing what they're doing. It's like you can't go 20 miles if you're running on feet that aren't used to it, you know?
Sure. You know, I think that's the problem the general public kind of puts out there, because there's this misnomer that, hey, you know, if you want to get fit and you want an easy way to get fit and a cheap way that doesn't cost much, take up running,
Right.
You know?
Right.
And any experienced runner, I would be frustrated with that number. Like, that's not true. Runners, they invest in their sneakers, their well-being, the gear they put on, the amount of physical toll running takes on the feet, the ankles, the knees, the hip. I mean, any runner can attest to it. So I'm not sure why that's out there. And the more people say these things and people just go out there randomly and start running 10 miles with no real rhyme or reason, you're going to see pathology, right? And a lot of that pathology, I'm sure we all see it here, are improper training and overuse, really.
Absolutely.
And, you know, that you could break it down. I could say about 30% of the patients that come to my office are improper footwear. I can truly say that. Yeah, 30% are improper footwear, you know, whether it be flats or heels or whatever it may be.
Wow.
So yeah, prehab is a big thing. And what you mentioned from the strike patterns and whatnot for the audience, that's very important, because we talk about the foot, the ankle, and the whole body. It's just one big chain. And the chain is only as strong as its weakest link. So if you're beginning on a weak foot or a weak aspect of the foot, guess what? You kind of disrupt that whole chain, right?
Right. Yeah. I mean, even talking about it earlier, like we mentioned that the Achilles tendon can withstand 10 times the body weight going through function movement. So for a tendon to be that strong and tear in an instant, like, you know, there has to be an underlying factor that people aren't considering. There's a reason why biomechanically you're going through that injury. It shouldn't just happen naturally, you know?
Right. And you know what's funny, or I shouldn't say funny, but ironic, that strong of a tendon, when we hear the histories of someone who tours it, is random for the most part.
Right, exactly.
I jumped up to take a basketball shot. I landed and I heard a gunshot. And I'm not exaggerating. I've heard that reference before. I heard a pop. I thought someone shot somebody, right? I thought someone took a tennis racket and hit me in the back of the ankle, because that's the amount of force it took for it to rupture. And chances are it was weakening as you were going on. And that was the last jump or the last sprint or the last cut that needed to be for it to pop. That's why it should be taken seriously.
Yeah. So we hit the prehab part, and so let's bridge this into the rehab. And I want to connect it just by this awesome study I read today, and it analyzed runners right after this rupture had occurred. So it checked out their biomechanical pattern. So like Jake was saying, like, where was their strike at? And basically it came up with two statistically significant results. And one was these runners were having too much dorsiflexion post-rupture. So what they were doing was excessively heel striking. And then on top of that, they weren't flexing their knee. So as they were coming down, their leg was very straight. And they were also generating this intense pressure up their leg, leading to knee issues. So that stresses, you know, just how much it might have happened, but we still need to analyze you. And then we still need to work on you and get that proper rehab so that you don't have to worry about those risk factors, so that, one, you don't re-rupture again, or two, you don't have to worry about a rupture on that other Achilles. So what a lot of people don't understand is that surgeons and physical therapists work very closely together on a lot of post-surgery stuff. A lot of our protocols come directly from you, but also we report back so that you know what's going on and we give that proper care. So can you just give us a good insight into, let's pretend you just got, a rupture, you did that surgery, and then how you go moving out with that rehab and working with a physical therapist?
Sure. So everything again is patient dependent. I can't stress that enough, because I don't want people to get this general guideline for Achilles ruptures. Depending on the severity of the rupture, the demand from the patient, and so forth, that kind of dictates how I'm going to approach this certain case. But a typical Achilles rupture, I'll reapproximate the ends and I'll keep them non-weight bearing, complete non-weight bearing for 3 weeks. That gives the incision enough time to heal, and the collagen, the fibers that make up the Achilles, that it takes about 14 to 21 days for them to cross fiber and cross link enough for them to retain enough strength that they once had. So once they're at the 3-week mark, that's when I transition them into a boot with a heel lift. So they're still going to be in a plantar flexed attitude, but now they're starting to put weight on it. Now, if you've ever seen these cam boots, they offload about 70 to 90% of the weight on the lower extremity. So it's a nice transition from cast to walking. So it's that nice happy medium. But at 3 weeks, I send them to the PT and I want their insight on things. What do you think they're capable of doing at this point? Would they benefit from any therapy at this point right now in their rehab? And that's when we work closely, because with all honesty, I have a certain protocol, but I need their insight to tell me, okay, this is this patient's limitations. We should stop here. Hey, we can move forward with this therapy. I think this patient's ready for active range of motion. And another misnomer is people are waiting for the doctor to clear them from surgery, right? They want their surgeon to clear them from surgery. In reality, I'm waiting for the physical therapist to clear them from surgery. That's true. As a doctor, we sit there, we'll do heel raise tests. We'll do jumping on one leg, jumping on another. But physical therapists, they have they have the means to test you in different ways. They have long hallways. They're having you do sprints, joggings, up, down, whatever it may be. So I never clear a patient to go back into physical activity until the physical therapist also agrees on that statement. Just because they work with you twice a week, maybe 3 times a week, and I'm seeing you after every 3-4 sessions. I think it goes hand in hand. You can't have one without the other. And if one person fails, we both fail. That's the reality of it. The surgery is only so much. I tell the physical therapist that I work with, and I tell the patient, we're all a team. And my job is to get you through surgery. Your job after that is to make sure you do everything you need with the physical therapist to get you back into activity.
Awesome. And we absolutely love to hear that. That's how we want to work with surgeons. That's how we want to work with the physicians, so that, like you said, if that person doesn't get where they need to be, we all fail. And it's not a matter of, we want patients to come in to generate revenue. It's not any of that. We want the best for our patients. And when everyone's on that same page, it's ideal.
Yeah. And I always set high standards. So I always use athletes as a reference, right? Because athletes have the best resources at their disposal, right? They have everything you could possibly need. And athletes take about 11 months to get back after Achilles rupture. So I always tell patients, don't feel bad. I know this is going to be a long run, but we care about longevity. What we care about is not how fast we could get you back, but getting you back at 100% and making sure you never have to go through this again. That's more important. What's not important is getting you back in 6 months so you could finish the season, or getting you back at 100% and giving you a 10-year career. You got to outweigh that. And that's when it matters. So physical therapy is very important. And anybody who knows me in the neighborhood will know that physical therapy is very important aspect of my practice.
Absolutely. And while we're on the topic of surgery, I just want to speak to something that we're both passionate about, which is the Haglund's deformity.
Yeah.
Just so the general public gets the idea of the bony spur on the back of your heel and the underlying cause being more biomechanical, and the need to not necessarily have that removed. Can you go ahead and talk to that for a few minutes too?
So the Haglund's deformity is known as something called a pump bump. So it's a bump on the posterior aspect of your heel. It's very prominent and palpable and can be irritated in certain shoe gear. There's something called the Haglund's triad, right? These are the 3 things that are often accompanied with the Haglund's deformity. One is insertional Achilles tendonitis, because the Achilles inserts on the back of the heel, and that chronic pull on the abnormal bone will lead to an inflammatory response. The second thing is the bump itself. And the third is a bursitis. So what happens is there's so much chronic pull on the area of the bone that your body will develop what's called a bursal sac, just to kind of decrease the friction or the inflammation in the area. Now that bursitis can also be painful as well, right? So you're dealing with three things. And when I actually do surgery on these patients, you'll resect the bursal sac. You'll see it. So you'll just take it out and get it out of it. Now, we talked about the root of the problem, right? Bone is unique. Bone, you got to be amazed with how bone works. If you break your bone, bone is so strong. If you're a healthy patient, you know, no comorbidities, no smoking, bone will grow back just as strong, if not stronger than its original strength. That's the beauty of bone. Skin and tendons and ligaments, they don't have that ability. You cut yourself or you do an incision on your hand, you're going to have a scar, right? Which is different skin tissue than your original. You rupture a ligament, you rupture the tendon. We all know the collagen isn't the same collagen it had. It's less elastic and a little more stiff than we'd like it to be. Bone, on the other hand, will have the same properties and density and everything you may need. So what happens is the Achilles will attach to the back of the heel. Now, chronic pull from that Achilles tendon, your body will respond, and bone doesn't play games. Bone will say, you know what? If you're going to keep stressing me, I'm just going to form new bone. And that's where the pump bump comes into factor. So in reality, I could treat the bump. I could remove the bump. You know, the surgery, I could remove the bump, detach the Achilles and the whole 9 yards. But if I don't address the fact that your Achilles is chronically pulling on that area, I'm not really taking care of you. I'm just putting a Band-Aid on the wound. So I'll do a biomechanical assessment on these patients, and a lot of them will have what's known as equinus, which is the lack of ankle dorsiflexion. So basically your ankle's constantly in a downward position, which means your Achilles is constantly pulling on that heel, which is going to cause friction, which is going to cause an increase of bone cells, and known as the pump bump. So that's the idea between a Hagelein's deformity. And it could be very troublesome because if it gets too big, it'll get to a point where shoe wear will become uncomfortable. They're just constantly rubbing in the back, and you really can't do anything about it, and except surgery. And don't get me wrong, surgery is not an easy thing. You're detaching the Achilles. Some people do it without detaching the Achilles, which is tougher. But for the most part, people detach the Achilles, shave off the bone, and then reattach the Achilles. So guess what? You're waiting 3 weeks for that Achilles to maintain strength, and then you're doing the rehab again. So if you could avoid that, you'd like that. If you get in the early stages of that, it's not too late to treat it. And I'm sure you guys could speak on this as far as people coming in with chronic Achilles tendinosis or acute Achilles tendonitis and working on that aspect.
Yeah, so off that kind of branch, we have in physical therapy what's called clinical practice guidelines. Clinical practice guidelines are made by our governing agency, and they pretty much break down injuries and what different methods say is the best way to treat those injuries, just as a general population. So there's a big portion out there for our clinical practice guidelines for Achilles tendinopathy that says obviously eccentric loading is one of the best ways to treat it. So that's the lengthening of the muscle while we're still applying tension to it. So that's considered an A category. That is the absolute best thing that we can do for Achilles tendinopathy. What's considered a B category kind of deals with that lack of blood flow. So this is more of our like laser intervention. This is more of our Ionto. The different type of modalities that are used to increase blood flow around the area to try to hope that we get some healing agents back to that tendon. Now, it's actually interesting because heel lifts, manual, and taping of the Achilles are all considered D and F level categories, which is really, really interesting considering that a lot of the intrinsic factors for biomechanical analysis of the Achilles tendon ruptures, you're fixing those with manual work. So it's really interesting that once the injury happens, that manual isn't as effective as if we were to do it beforehand and try to avoid the injury in the first place.
Right. So heel lifts, if you look at the rear stitch, some people swear by them and some people say, no, what do you, it's making it worse. Right? If you look at it from a simple sense, it makes sense, right? So if the Achilles is constantly under strain, you put this heel lift. So basically it takes off the tension off the Achilles. So your Achilles is naturally more lax, right? Mm-hmm. But now if you have the opposite of a chronic Achilles pull and you have calcaneal gait or too strong of extensors, it's going to have the opposite effect. So again, just like we mentioned before, this is going to be a patient-dependent thing, heel lifts. But the beauty of what we spoke about in the beginning and how we're going to tie it in right now, and I hope if anyone's a nerd like me, this should blow your mind, right? So we talked about the Achilles and the vascularity and why that's important. Remember, we mentioned proximal, distal, we're okay, but in the mid portion, we're trying to get blood supply. And your category A's and B's, what did you continuously repeat on why they work?
It's all about the blood supply,
That's
supplying
it.
more blood to the eccentrics.
That's it. And heel lifts don't do that.
Right. Exactly.
So that's how everything ties in. So the idea of laser therapy and iono is it just vasodilates. So what happens in
Right.
with your body, it has the acute phase. And in the acute phase, your body just sends all the blood and growth factors and healing factors to one area. Just boom, 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 getting it to where it needs. But eventually it stops doing that and it kind of tapers off. All right. And if it tapers off too quickly or too long, eventually you didn't get enough to the area for it to heal. And that happens a lot with the Achilles because it has that watershed area. So what those modalities do, they kind of recycle that phase so they could supply more nutrients, more growth factors, and more healing factors to the area. But that's why blood supply is critical. That's why people who smoke, we tell them, hey, if it takes 6 weeks to heal, you know what? You're going to be 12 because smoking vasoconstricts the vessels. Or people with hypertension who just naturally have smaller blood vessels, hyperlipidemia, where their blood vessels are clogged with fat and cholesterol. These are all, it's just a repetitive theme. It's all about the blood supply.
Yeah. And one of the most important things is that when you are using those modalities and getting that blood supply better, that's not enough. So you need to also get that motion in once you have the blood supply there. And that's the key because that's how we progress along our rehab, right? So these things have pretty good ratings because they help out right then and there, but they give us a higher stepping stool so that we could push a little further, go a little better, and then we get that rehab to where we need it to be.
Yeah. You know, what's funny is this is what I marvel at in physical therapy, because when we treat patients for Achilles tendinosis, Achilles tendonitis, or let's just say plantar fasciitis, right? Kind of same idea, chronic pull, fasciosis, whole 9 yards. I always tell patients, this is going to be the treatment between balance and stiffness. Like we have to balance stiffness and mobility. And that line can sometimes be very thin, right? So we have to constantly make sure. That's why you go to PT twice a week, right? Because yeah, they're going to try to heal you, but at the same time, they don't want you to get too stiff. So they're constantly assessing that. That's why you come back and you see me after every 2 to 4 sessions, because I want to see how you're progressing. So again, just like you mentioned, it's not just blood supply, it's mobility, because having a lax ankle or a lax tendon is bad, but having a stiff one can be just as bad too.
Absolutely. And that gets right into gait and everything else. So if we can't progress you to a point where we feel like your gait isn't compensating, then we got to kind of reassess the weight bearing at that time. So that's always a really key thing, and something that has been stressed in our program is that if they still have those compensation patterns, it's only going to add up over time. And what's going to happen is you're going to lose mobility elsewhere in your body. If we go up that chain, it's going to affect the knee. It's going to affect the hip. It could even, it's going to affect your low back and your pelvis.
Oh, I see it all the time.
Yeah. So that's a thing that a lot of people definitely think about. They're like, well, I got to worry about my ankle, right? That's what I hurt. That's right where it's at. We have a whole kinetic chain, and everything's got to work perfectly and sound with each other. So that's one of the biggest things that we always like to stress, and we're glad you do too.
Oh, absolutely. You got to have a holistic approach, and unfortunately, especially we sometimes get caught up in our own niche. So we'll only focus on the foot or only focus on the ankle and never consider that, maybe there's something else going on here. But we're seeing it more and more often. Chiropractors will send me patients and say, I've been treating this patient's lower back for quite some time. I don't know. Maybe they just have some limb length discrepancy. Maybe it's coming from the foot or ankle. Can you just check them out, right? And that's the idea behind the kinetic chain and the holistic approach. And the reality of the matter is that people are living longer, right? There was a time and day where people lived up to 30 years old, and the most common cause of death was diarrhea. Like that wasn't too long ago. Now we're living up to 100, and saying, oh, God bless, that's happening. Chances are that's only going to increase as time goes forward. So we have to make sure our bodies are ready for that. You want to live to 70, but you don't want to feel like you're 80 when you're 50, right? So you want to always have optimization. And part of that is getting an evaluation pre-injury or pre-occurrence, right? And that's the hardest thing to say. But if we kind of beat it into people's heads that if you're an athlete or you're a trainer, or this is something you take seriously, you should get it. It's just like going to your primary care physician once a year. You may not have anything, but you still go, don't you? And it's going to be the same idea as far as in the athletic realm.
Definitely. And there's definitely some things that are coming up too that I think it's going to keep getting better and better. The whole telehealth thing, like concept that we're kind of pushing right now, like getting people over the internet, over social media, anything we can do to push ideas into their head on a daily basis, that's massive. And then the direct access, I mean, that being passed, so people can get into the clinics faster without having to wait weeks for appointments that might not be schedulable. You know, like it's just getting that person face to face with you sooner has become such a priority that hopefully we can reduce these risk factors faster and faster and prevent some of these injuries in the long term.
Absolutely. I mean, if you carry that mentality, I think the patient will appreciate you for sure. I can't see it. I mean, it may take some time, but honesty is the best policy, right? And if patients don't care, they don't care how much you know till they see how much you care. And believe it or not, you know, we're all human. So sometimes we may have a misdiagnosis, or we may start a different treatment that wasn't the right path. But if the patient genuinely knew you cared, you really believed in your heart this was best, they tend to forgive. So always having that is important.
And so one thing that we immediately bonded over when we were discussing and trying to set up this call was, hey, there's a lot of stuff out there, a lot of stuff on the internet, and
don't get me started.
And we genuinely, along with yourself, just want to give good information. And we appreciate that there's others out there. So I think one of the biggest things that we could do for people tuning in is giving them a big thing to take away from this. So if you were to give someone your favorite, let's say, exercise or something to work on to help prevent this, if you were to get them into your clinic and say, all right, you know, ankle dorsiflexion might be lacking, something like that. So let's go for the most generic thing that someone could take away. Say, hey, let's try and work on some prehab to prevent this.
Yeah. So this is where you have to put your pride down, right? So my job as a clinician is to diagnose, assess, and manage a patient. When it comes to the prehab and rehab aspect, I'm going to entrust the physical therapist and the trainers with that duty, right? So I'm going to sit there and diagnose you, but why not send you to someone who does this for a living? 6-7 years of schooling and training and whatnot. And I have no shame in doing that. That's why, believe it or not, and any physical therapist who's listening, who works with me knows, before I refer patients to you, I go to your facility, I meet you, I want to get to know you. What's your train of thought? Are we on the same page here and whatnot? Because it's important. So that would be my take. My job, you come in, I'll do a full evaluation as best as I can. And if I find any deficiencies, if there's something that I could correct, whether it be through orthoses or footwear and whatnot, I will. But if it becomes an activity assessment or exercises or stretches, that's when the referrals come into play.
Well, we definitely appreciate that.
Oh, absolutely.
Can't speak.
But yeah, I guess from our aspect, a big thing that we would want everyone definitely to work on is understand how tight your, what we call triceps surae, but your soleus and gastroc complex are together. It definitely plays an effect on it. And I think Jake touched on another big one earlier is assess your running style and have someone assess it for you. But if you are that avid heel striker and you're trying to go big miles, it adds up for sure.
Oh, absolutely. Absolutely. Couldn't have said it better myself, but that it goes around the theme that we were talking about. That's why a proper evaluation is crucial.
Yeah. And everyone's different. Everyone's individualized. And we appreciate everyone as an individual person.
Absolutely.
Awesome. So we're really excited because this is on Zoom and there's a 40-minute limit, and we got an alert that was like, oh, cool, you guys are doing great. So, you know, keep going. So clearly they knew it was a good conversation.
I think it was. I really wish I had something like this as a student, because we kind of compacted everything Achilles into one session. And I definitely appreciate your guys' information. You know, I'm big on academia. I'm a huge nerd. I don't hide it from anybody. You have to have a passion for what you do, genuinely. You really do. If you think the studying and the research ends at medical school or residency, then you're just doing it wrong. When I stumbled upon your page, I was just ecstatic, because your guys' description and videos were just spot on. They really were. And I commend you guys on that for sure.
I really appreciate that. And, you know, hopefully this is one of many videos that we get together.
Yeah, I sure hope so, for sure.
We're restraining ourselves to not go into plantar fasciitis. Right?
We could go on a rant.
I'm like, man, we could really go on a rant right now.
We could go on a rant for sure. But it leaves it open for discussion for other topics for sure.
Absolutely. So, Mohammad, thanks for your time. We really appreciate it. We know our listeners do, and we hope your listeners do. Yeah, thanks for your time tonight.
I appreciate you guys.
All right, have a
Man,
good
you have a
night.
good one.
You too. Take care.